All right, we're live.
All right, good morning. It is February 2nd. This is the Senate Health and Welfare Committee meeting, and thank you for joining us. We have a couple of things we're going to look at today, and then at the end of our testimony from our two ledge councils, we'll take a minute just to lay out what's coming up. We might do that even before we get to S48, but I'd like to just talk a little bit about our work and what's coming in the next week or two. And before we start, I'd just like to say that as we set up the agenda for this week, our goal was to look at the Budget Adjustment Act. Unfortunately, the administration has been out straight, and their schedules are probably fuller than ours at this point. So many of them couldn't come in a timely way for us, and they've been moved around a little bit. So we've also then had to move around testimony and bills that we're looking at. But the focus that we're going to have today is on the flexibility bill, and then we'll get a first look at the nurse compact bill. And these two bills will be important to us going forward. And then we'll talk about some others later in the meeting. So Jen, thank you for being here. And you did go through the sort of the deadlines that we were looking at, and now we have some draft language. How do you want to do this? I know the committee may or may not have questions. Do you want to go back to and I look at the committee for this as well, do you want to go back to the table, or are you interested in looking at the draft language that we have on our webpage? Doesn't matter. Okay, so we'll go, Jen, it's your choice. Senator Hooker, go ahead.
Thank you. Can we just have an explanation of, what this bill is? Because I'm not sure. I haven't had a chance to read it.
Okay, this is the bill that we Jen, why don't you kick that part off? And just to tell you that this is a COVID-related bill, and it is very much related to the work that we did during the session last year, ending in September. So Jen, I'll turn it over to you.
Okay, thank you. Jennifer Carby, Legislative Counsel. So what we are looking at is related to what we looked at last week regarding Acts 91 and 140 from last session that had a bunch of regulatory flexibility provisions around the COVID-19 pandemic. There has been interest in the, I think particularly in the provider community, in extending some of those provisions and also tying them to more of a date that would travel with the duration of the pandemic. So I think their request was 3 months, that most of these provisions expire 3 months after the state of emergency ends.
Okay, so this bill is
trying to pinpoint a date. So that's what this bill does.
Carrying on with that discussion, and you'll tell us what those extensions are.
Exactly. And then a couple of things to note on here as well. So the bill also does authorize the Department of Financial Regulation to adopt rules expanding patient access and provider reimbursement for audio-only telephone services. The bill has that through or until January 1st, 2024. So through 2023, that is an issue that the House has been taking a lot of testimony on. And so they may have some recommendations, and you can decide what you want to do with those. But right now, that's what the request had been, was to extend that particular provision. So you'll see that one piece looks different from the rest.
So, and I just to interject here, because that's an important point to be made. And I have talked with Representative Lippert on a regular basis about this. So the work that they're doing on the telephone only will help inform any decisions that we make. And we'll pick up their recommendation and then listen to folks and see how that works. And then one other comment about this. the bill has not been introduced. This is draft language. And my intent is to just have it be a committee bill so we can pass it out when we're ready to have it go. That's all.
Okay, so at the moment it has Senator Lyon's name on it, but that
That's all.
can easily change. And all right, I'll leave it there. So let me put this, attempt to put this over on this screen. So should I just put up the language? Is that going to be?
Yeah, why don't we do
easiest way?
that? And that,
Okay.
I mean, that'll be good. And then everyone has a table we looked at on Friday. And if you need to go back and reference the shorthand, it's there. But I think it's good to look at the full language.
Okay, so are you able to see the document now?
Yes.
Excellent. So it starts off again with, statement of purpose is basically what I just summarized for you. So I titled it an act relating to extending healthcare regulatory flexibility during and after the COVID-19 pandemic. And so this reaches into Act 91 as amended by Act 40, Act 140. That's the case for most of the provisions. And then there are a few at the end that were just in Act 140. So the first section here is right now allows the Agency of Human Services through March 31st of this year. This would instead say during a declared state of emergency in Vermont as a result of COVID-19 and for a period of 3 months following the termination of the state of emergency, that the Agency of Human Services must consider modifying existing rules or adopting emergency rules to protect access to healthcare services, long-term services and supports, and other human services under the agency's jurisdiction. And it also directs the agency to consider the importance of the financial viability of providers that rely on public funding for a majority of their revenue. So then the next piece, and these reader assistance headings were in from the bill, from the original bill, but I think they're still helpful in orienting you to what the topics are.
And Jen, sorry to interrupt again, but I failed to say to the committee, I can't see you all. If you have a question, just do as I did and speak up. Thank you.
And you'll notice also this was, the first section was section 1, section 2 of the underlying bill is not being amended because that was one that already had the flexibility, the date flexibility built into it. So it was for the state of emergency and for 6 months after. Section 3, this is language that we had talked about last week that directs healthcare and human service facilities and providers to protect their employees who are not licensed healthcare professionals from the risks associated with COVID. And as we talked about, there had been a lot of effort at getting PPE and other safety measures for the healthcare professional staff, and the committees had been concerned at the time also about the non-healthcare professional staff in those facilities and providers. And so this again would change that date from March 30 through March 31st to during a declared state of emergency and for 3 months following that, the termination of the state of emergency. Next,
Sorry, this provision seems both obvious to me and like, what are they just not gonna, if we took this away, they would just not protect their employees? Was there testimony saying that they were not doing it? I mean, I understand the fear. I'm concerned that they wouldn't just always protect their employees from the risk of infection, whether it's COVID or anything. I mean, I'm not saying we shouldn't do this, but it just seems like illogical to me.
Well, it does seem that way to us, but honestly, there are folks out there who might not think that the guidance or the rules that are put in place are appropriate. So this just ensures that public health guidelines are followed.
Yeah.
And might this have anything to do with funding that comes to the agency for those purposes? I mean, just kind of showing that this is what they're doing with it? No.
I mean, this language was really just directive to these facilities. It also, and it tells them really to follow guidance from the health department. And it also is qualified with to the extent feasible. I think this was, really to call out concerns, particularly among workers who were not necessarily interacting with patients directly, and so we're concerned that they would be exposed without the same level of protection that other employees of the same facilities would receive. And so the legislature at the time had chosen to call that out and has continued to extend it.
And just so you know, we have a bunch of folks coming in tomorrow when we're meeting with the House Healthcare Committee, who will be able to provide testimony on the bill. So we can ask that question again if you'd like to. Go ahead, Jen.
Okay, section 4 is around provider or compliance flexibility, and this is saying notwithstanding any provision of the Agency of Human Services administrative rules or standards to the contrary, and then again extending through a declared state of emergency and for 3 months after, the Secretary of Human Services may waive or permit variances from certain state rules and standards governing providers of healthcare services and human services as needed to prioritize and maximize direct patient care, support children and families receiving benefits through DCF, and allow for continuation of operations with a reduced workforce and with flexible staffing arrangements that are responsive to evolving needs. And then again, always with the qualifier that it's only to the extent that these waivers or variances are permitted under federal law. And then I left these in here just so that you could see them. We're not making any changes to them here, but these are the hospital licensing rule, hospital reporting rule, nursing home licensing and operating rule, home health agency designation and operation regulations, residential care home licensing regulations, assisted living residence licensing regulations, home for the terminally ill licensing regulations, standards for adult day services, therapeutic community residences licensing regulations, choices for care, high and highest manual, designated and specialized service agency designation and provider rules, the child care licensing regulations, public assistance program regulations, foster care and residential program regulations, and other rules and standards that the Agency of Human Services has adopted by rule.
So if you put this little section together with the previous section about ensuring that folks working in some of these places are protected, then it kind of makes sense to have that earlier provision. As if you're reducing some of the rules and regulations in some of these areas, then you want to make sure that that doesn't include a lack of protection. I mean, I guess I would think about that a little bit.
And this is a may, I notice that the secretary may do this. Do you know if he has done this?
It's a great question, and I do not know. That may be something that you want to hear from the agency. I think there are a few provisions you may want to. The one that wasn't in here because it didn't need extending, but the provider tax flexibility piece as well. I'm not aware that that's been used. It does require joint fiscal committee approval, and I'm not aware that that was sought. So I presume it has not been used, but it might be useful to ask the secretary or someone from the secretary's office about both of these.
Okay, yeah, because I'm just curious what the implications have been, if any of these have been relaxed.
I honestly, it's a good question, and I do forget whether or not the LCAR has seen any of these rules come through.
I don't think you would, because this is really allowing the secretary to waive or allow variances from existing rules. So it didn't require adoption.
Okay, a good question that we can ask tomorrow when we have some folks in.
Yes, and I made a note as well, so we'll make sure.
Good, thank you.
We can get you an answer. Yeah.
And Jen, is it possible to send a quick email out to the secretary rather than drag everyone in for each of these questions, just to get an answer, a response to that.
Sure. Yep, I
Okay,
can
that'd be
follow up
helpful.
and if
Yeah.
anyone from the Secretary's office is watching and wants to reach out to me, that's great too.
That would be terrific. Far superior.
All right. So section 6 is around provider enrollment and credentialing, both in Medicaid and for health insurance. So this one is written a little bit differently and actually brings up an issue that you may want to discuss with the healthcare committee tomorrow, which is around the different types of states of emergency. So this one is phrased as until 3 months following the termination of the last to terminate of a declared state of emergency in Vermont as a result of COVID, a declared federal public health emergency as a result of COVID. That's one that the the Secretary of the U.S. Department of Health and Human Services declares, and a declared national emergency as a result of COVID-19. That's one that one of a few that the president declares. So until 3 months following the last to terminate of those, and to the extent permitted under federal law, the Department of Vermont Health Access must relax its provider enrollments for the Medicaid program, and the Department of Financial Regulation must direct health insurers to relax their provider credentialing requirements for health insurance plans in order to allow for individual healthcare providers to deliver and be reimbursed for services provided across healthcare settings as needed to respond to Vermonters' evolving healthcare needs. So in case this one isn't clear, this is really trying to make sure that providers can move across settings in delivering healthcare without having restrictions placed on that mobility by the health insurers or by Medicaid, the DIVA, so that they can get reimbursed for those services. And this piece on the different types of states of emergency, we can look at whether similar language, not necessarily on all three of those, but similar language about which one you want to peg your timing to should be used. All right, then we get into access to healthcare and human services. So the first piece is around emergency rulemaking, and this is the Department of Financial Regulations emergency rulemaking. This one, it says it is the intent of the General Assembly to increase Vermonters' access to medically necessary healthcare services during and after a declared state of emergency as a result of COVID-19. And this would change this lead-in language to say during a declared state of emergency in Vermont as a result of COVID-19 and for 3 months after, and notwithstanding any provision of the emergency rulemaking statute, that's 3 VSA section 844. To the contrary, the Department of Financial Regulation shall consider adopting and shall have the authority to adopt emergency rules to address the following. And this one gets a little bit different because, and I'm actually realizing that I think I need to go back in and take this one out and handle it separately because it was amended by Act 159 as well. But they need to consider and have the authority to expand insurance coverage for and waive or limit cost sharing requirements directly to COVID-19 diagnosis, treatment, and prevention, and modifying or suspending health insurance plan deductible requirements for all prescription drugs, except to the extent that that would disqualify a high deductible plan from eligibility for health savings account under federal law. I'll pause here for a moment and say, DFR did adopt emergency rules on both of these, and actually on the third piece as well, on a few different occasions, and they sort of, continually refined those rules. So they did expand health insurance coverage and waived or limited cost sharing requirements for COVID diagnosis, treatment, and prevention. They also suspended health insurance plan deductible requirements for prescription drugs for preventive services. Those are the ones that could be done that way without disqualifying a high deductible plan from eligibility for a health savings account. So under federal law, there are only certain things that plans can cover first dollar, meaning without any out-of-pocket responsibility, without without making them ineligible for a health savings account. So hopefully that was reasonably clear. So any rules adopted in accordance with this subsection, so now we're separating this out from the third piece, would remain in effect until not later than 3 months following the termination of the state of emergency. Then I split out as a separate subsection C, this audio only piece. So Department of Financial Regulation would also consider adopting and have the authority to adopt rules expanding patients' access to and providers' reimbursement for healthcare services, including preventive services, consultation services, and services to new patients, delivered remotely through telehealth, audio-only telephone, and brief telecommunication services. And any rules adopted in accordance with this subsection would remain in effect until not later than January 1st, 2024. So this is the piece I was foreshadowing earlier that would run through 2023, or could run through 2023.
So the one piece, I think, the audio only telephone, can you talk a little bit about a distinction between that and some of the other services that are listed there in terms of how things are going at this point?
Sure. So in general, and there are lots of different definitions for all of these things, but telehealth is kind of a broad umbrella term that encompasses what we refer to as telemedicine, which is the live, interactive, audio, video communication where healthcare services are provided in real time with a patient in one place and a provider in the other, but it has audio and video involved. So sort of like Zoom, but in normal times, regular Zoom is not allowed because it's not HIPAA compliant. It is being allowed right now. So that's telemedicine. That's one piece of telehealth. Then there's also store and forward, which is where an image or other information is captured in an electronic format and transmitted to a provider to analyze or interpret, not in real time. So that is sort of stored and forwarded to be read by a distant site provider at a later time. And then there's also things like remote telemonitoring. That's something that home health agencies in particular can use to remotely monitor a patient's vital signs or weight or other things that would give indications about the patient's health without requiring a visit by the home health agency or other provider. And then this idea of audio only telephone, so just a phone call between a patient and a provider, has also been kind of included in this idea of telehealth. That is not something that is typically reimbursed as a service under health insurance plans or Medicaid. So under these circumstances, DFR has required health insurance plans, and Medicaid has also complied with allowing audio only telephone to be a way to deliver services. So a patient could have a doctor's appointment or other medical appointment with audio only. And so there was, as you may recall, the audio only telephone study group that the department was also directed to convene, and came back with a report and some recommendations on continuing to cover audio only telephone services even after COVID is over. But there was not, I think, agreement on in what circumstances or what the reimbursement should look like. So that is the piece that the healthcare committee has been taking a lot of testimony on. So this piece would continue at least DFR's authority to adopt rules expanding patients' access to and providers' reimbursement for audio only telephone services. So assuming that 2023, the end of 2023 is beyond the end of we're beyond 3 months after the end of the state of emergency. So this would make a policy decision on that piece, at least for a 2.5-3 year period.
And so just a couple of comments, and I'll start with the telephone audio only, that right now, physicians or practitioners use the telephone to communicate with their, if under the fee-for-service world, after, in an office visit or after a surgery or outpatient care, providers do talk with patients, but in a fee-for-service world, they aren't reimbursed for all those telephone contacts. There might be some for private insurance or others that allow for payment, but basically, when you call up your patient and say, how was the tonsillectomy, that's not paid as a fee for service for each call. In the COVID world, telephone has become so much more important to people that now there is a reimbursement for that. Unfortunately, we have some support from the federal government to allow that coverage. Going forward, the question is, in a fee-for-service world, then, how do we continue this access, but at the same time not have get into the red, payment red, and so that's the issue. In the all-payer model world, maybe there's a way to cover telephone calls and to a certain number or extent. So those are kind of I see a little bit about kind of the practical problems associated with this and how we make those decisions. The House is taking the lead on this right now. We do have a report on audio only somewhere in our reports, and we probably should look at that as we're talking about this bill. We can do that alone. We don't need to have Jen go through it with us, I think. The other question I had in this area, Jen, is what you brought up around HIPAA compliant. And right now, the Zoom process and equipment is not necessarily HIPAA compliant, but providers are allowed to use it, and we use it for our medical appointments. So my question is this, and it may be a Nolan question, and we'll have to pick it up as we go along. And maybe some of the providers who are listening in can help us. There was CARES funding, and now maybe there's more federal funding available for clinics and individual providers to purchase HIPAA compliant technology. So the question is that going on? Is it available? So that once we come out of COVID, then more providers would be HIPAA compliant. So that's a different kind of a question, but.
Right, and I think some of that has to do with the actual program that's being used. So that would be an ongoing cost that wouldn't necessarily be eligible for CRF.
Exactly my question. Is it something that's ongoing, or because HIPAA compliance was not required, then none of the coverage for new technology that achieves HIPAA compliance. It gets to be a tangled web, so we'll have to sort that one out. What is the guidance on that? I don't know. And again, maybe some of the providers who are listening in can help us with that, answer that question tomorrow or another time.
Madam Chair.
Go ahead.
I'm happy that you brought up the sort of fee for service versus ACO model, or whatever the dichotomy is there. I'm thinking about this morning the prayer we had on the floor about dichotomies, and this just seems to be one of those dichotomies, because it seems like a schizophrenic thing we're doing here. On one hand, we want to be able to reimburse providers for the work they do, including lengthy telephone calls and video services with patients. And on the other hand, we want it all included in the sort of package of patient care delivery. Obviously, right now during the pandemic, things are different, but it seems to me that we need to reconcile that schizophrenia as we move forward about what is it we want to be doing here. Do we want to be sort of continuing to reimburse on a fee-for-service basis, even as we expand ways that we provide services? Or do we want to say we want to include it all in the same package of patient care? So anyway, I'm interested to see what the House is talking about. And also, I know from some providers are investing in other types of technology that is HIPAA compliant and using it right now. So I think it'd be interesting to hear from them, but I do know that they are doing that. They're not just relying on.
They are. The question is what is the guidance around that on the CRF dollars, on the CARES dollars, and on the continuing federal funding that we're going to see. So, and then there's a whole packet of money that's available only to providers, and how if can they use that to upgrade to HIPAA compliant? Yeah, no, it's a very important question. And just to fine tune the question that we ask about fee for service and all payer, even within that, it may be that in the fee for service world, there is a limited number of telephone calls that are covered under certain conditions. So then you start to get into what the insurance company decisions might be about how many phone calls and what kind of patient will be paid for on a fee for service basis. Or in the all payer model, you might be getting into how many counseling sessions will the audio only be allowed. So there's a lot of detail in this at the provider level that becomes clinically important. I don't know how we solve all of that ourselves, but at least this is something we should be aware of.
Okay. So our next few sections deal with prescription drugs. The first one allows it requires health insurance plans and Medicaid to allow their members to refill prescriptions for chronic medications early, so that the members can maintain a 30-day supply of each prescribed maintenance medication at home. And under current law, this provision lasts through June 30th of this year. This again would change that to be during the state of emergency and for 3 months after. And as I think we talked about when we looked at this, the definition of maintenance medication does not include a regulated drug, which is a controlled substance, but it is a prescription drug taken on a regular basis over an extended period of time to treat a chronic or long-term condition. So that's section 9. Section 10 also moves from June 30th until to be 3 months after the end of the state of emergency. And this is the provision that allows a pharmacist to extend a previous prescription for maintenance medication if the patient has no refills left or the authorization for refills has recently expired, if it's not feasible to obtain a new prescription or refill authorization from the prescriber. And the pharmacist has to take all reasonable measures to notify the prescriber of the prescription extension in a timely manner. And we use the same definition of maintenance medication. Section 11, which currently lasts through March 31st, and again would go until 3 months after the state of emergency, is the provision allowing a pharmacist, with the informed consent of the patient, to substitute an available drug or insulin product for an unavailable prescribed drug or insulin product in the same therapeutic class, if the available drug or insulin product would, in the pharmacist's clinical judgment, have substantially equivalent therapeutic effect, even though it is not literally a therapeutic equivalent. And as soon as reasonably possible after doing that substitution, the pharmacist must notify the prescriber of the drug or insulin product dose and quantity actually dispensed to the patient. Next, we have buprenorphine prescription renewals. And again, this would extend, instead of through March 31st, would last until 3 months after the termination of the state of emergency. And to the extent permitted under federal law, would allow a healthcare professional who's authorized to prescribe buprenorphine to treat substance use disorder to authorize renewal of a patient's existing prescription without requiring an office visit. Section 13 is the 24-hour facility and program bed hold day reimbursement. So this again would be, instead of through March 31st, it would be 3 months after the end of the state of emergency, and to the extent permitted under federal law, This would allow the Agency of Human Services to reimburse Medicaid-funded long-term care facilities and other programs providing 24-hour-a-day services for their bed hold days, when they're holding a bed for a patient or resident who is temporarily elsewhere, like a hospital.
I will say sorry.
Oh, I was just going to make a note to follow up on this one as well to find out if this has been happening.
Right. I was going to say that, and
Okay.
to see what effect it's had given the serious condition of some nursing homes.
All right. Then we move into the regulation of professions. So section 17 says, notwithstanding any provision of our licensing rules or statutes to the contrary, and again, instead of through March 31st, it would be until 3 months after the termination of the state of emergency, a healthcare professional, including a mental health professional who holds a valid license, certificate, or registration to provide healthcare services in any other U.S. jurisdiction, would be deemed to be licensed, certified, or registered to provide healthcare services, including mental health services, to a patient located in Vermont using telehealth or as part of the staff of a licensed facility, as long as the person is licensed, certified, or registered in good standing everywhere else that they hold a license, certificate, or registration. They're not subject to any professional disciplinary proceedings anywhere, and they're not affirmatively barred from practice in Vermont for reasons of fraud or abuse, patient care, or public safety. And if they plan to provide services in Vermont as part of the staff of a licensed facility, then they must submit or have submitted on their behalf their name, contact information, and the location or locations where they will practice to the Board of Medical Practice for medical doctors, physician assistants, or podiatrists, and the Office of Professional Regulation for all other health professions. So they don't have to register if they're doing telehealth, but they do have to register if they're going to be physically present in Vermont. A healthcare professional who delivers services in Vermont under these circumstances is subject to the imputed jurisdiction of the Board of Medical Practice or the Office of Professional Regulation. And this section would remain in effect, again, moving out that date until 3 months after the termination of the declared state of emergency, and as long as the professional remains licensed, certified, or registered in good standing. Section 18 is the piece around retired healthcare professionals. So again, instead of through March 31st, this would be during the state of emergency and for 3 months after. A former healthcare professional who retired not more than 3 years ago with their Vermont license, certificate, or registration in good standing may provide healthcare services to a patient in Vermont using telehealth or as part of the staff of a licensed facility after they give the Board of Medical Practice or OPR their name, contact information, and the location or locations where they will be practicing. So that one is true for both telehealth and if they're going to be working on site. And again, a former healthcare professional who returns to the workforce using this authority would be subject to the regulatory jurisdiction of the Board of Medical Practice or OPR. And then again, through, or instead of through March 31st, it would be for during the state of emergency and for a period of 3 months after. The Board of Medical Practice and OPR may allow former healthcare professionals who retired more than 3 but less than 10 years earlier with their Vermont license, certificate, or registration in good standing to return to the healthcare workforce on a temporary basis to provide services to patients in Vermont. It allows the board and OPR to issue temporary licenses to those individuals at no charge and to impose limitations on their scope of practice as the board or office deems appropriate. Section 20, again, moving from the March 31st date to during the state of emergency and for 3 months after. This allows the director of OPR and the Board of Medical Practice in Subdivision 2, if they find that a regulatory body attached to them cannot reasonably, safely, and expeditiously convene a quorum to transact business, allows the director of OPR or the executive director of the Board of Medical Practice, as applicable, to exercise the full powers and authorities of that regulatory body, including disciplinary authority. The signature has the same force and effect as a voted act of their respective boards, and a record of their actions has to be posted conspicuously on the website of the regulatory body for OPR, on whose behalf the director took action, and for the Board of Medical Practice by the executive director on their website. Section 21 also extends through the declared state of emergency and for 3 months after, instead of ending on March 31st, the authority of the director of OPR and the Commissioner of Health to issue orders governing professional activities and practices that may be necessary to protect the public health, safety, and welfare. If the director or commissioner finds that a professional practice act offering therapy or procedure by a licensed individual in Vermont is exploitative, deceptive, or detrimental to the public health, safety, or welfare, or a combination, the director or commissioner can order a cease and desist order, and a violation would subject the person to professional discipline, may be a basis for injunction by the Superior Court, and in the case of OPR would be considered unprofessional practice. All right, then we jump into telehealth. So most of the provisions around telemedicine that were enacted as part of Act 91 were statutory, so they did not need extension. They were not time limited, but this is the piece we'll look at around HIPAA compliance, among other things. So this is waiver of certain telehealth requirements during and after the state of emergency. So this would say, again, no longer just through March 31st, but during the declared state of emergency and for 3 months after, certain provisions related to the delivery of healthcare services through telemedicine or by store and forward means is not required to the extent their waiver is permitted under federal law. The first is this requirement to deliver healthcare services using a HIPAA compliant connection. That's the full name of HIPAA is the Health Insurance Portability and Accountability Act of 1996. If it is not practicable to use a HIPAA compliant connection under the circumstances. And this we have had the authority to do because the federal government has announced enforcement that they're using enforcement discretion and not enforcing the HIPAA compliance requirement for telehealth at this time. Also can waive a requirement that the representation to the patient that the healthcare services would be delivered using a HIPAA compliant connection if it is not practicable to use the connection under the circumstances. And third, a requirement that they obtain and document a patient's oral or written informed consent for the use of telemedicine or store and forward technology before delivering services to the patient, if obtaining or documenting the consent or both is not practicable under the circumstances. So that's the end of the pieces that are just Act 91. Then we get to the two pieces that were enacted in Act 140 and extend these. So again, instead of through March 31st, it would be during the state of emergency and for 3 months after. A board or profession attached to OPR may issue a temporary license to an individual who is a graduate of an approved education program if the licensing exam required for the profession is not reasonably available. And this is not limited to healthcare professions. This is any OPR profession.
And this was reviewed, and I'll make sure that GovOps also reviews that again, because I don't know, I have no clue about plumbers.
Section 3 is some flexibility for the Board of Medical Practice. So this allows the Board of Medical Practice or its executive director to issue a temporary license. And again, this would be beyond just March 31st, but during the state of emergency and for 3 months after, issue a temporary license to an individual who's licensed to practice as a physician assistant, or podiatrist in another jurisdiction, whose license is in good standing and who is not subject to disciplinary proceedings in any other jurisdiction. The temporary license would authorize the person to practice in Vermont until not later than 3 months following the date of the termination of the state of emergency, as long as they remain in good standing. And it also would allow, again, during the state of emergency and for 3 months after, instead of just through March 31st, the Board of Medical Practice or its executive director to waive supervision and scope of practice requirements for physician assistants, including the requirement for documentation of the relationship between the physician assistant and physician, and allows the board or executive director to impose limitations or conditions when granting a waiver under this subdivision. And it would take effect on passage.
All right. Why
Should
don't
I
we?
Take it down?
Yeah, why don't we pull that down? And I just lost there it is. My picture of it. Okay, so just to clarify that Act 140 begins on page 16 of the bill, and that's why things get a little bit disjointed from the Act 90 stuff.
Right, so the Act 91 was as amended by Act 140. I actually, on reviewing it now, realize I need to pull out one piece of that and make it its own section, which is probably just as well because it's the piece that has the audio only in it anyway. But
yeah, good.
But that was also amended by Act 159, and somehow I did not incorporate that in there.
Well, how can you? There's a lot going on. It's impossible to keep it straight. So
this is why statute is easier than session law for the most part. Easier to amend.
Yeah, I agree with you. Okay, let me ask you that question, and then we'll. I know that there are questions here. How much of this is session law? This
It's all
is
session law.
Session law.
Yeah, because it's time limited. I mean, it doesn't actually make sense to codify it because it is time limited.
Okay, that's useful. All right, so questions. I think I saw Senator Hardy's hand up, so let's start there.
Yeah, thank you, Madam Chair. I think just in general, and Jen, I know you don't know the answer to this, but I'm just curious how many of these provisions have been used and what has the impact of their use been. I think it makes a lot of sense to extend these flexibilities, but before we do it, I'd just like to get at least testimony about whether they've been used and if the impact has been positive. I would hope so, but these regulations are in place for a reason, and most of the reason is because of health and safety. And so we wouldn't want to be continuing to relax them if bad things have happened, let's just say. And if they have been relaxed and it's all gone super well and there haven't been any problems, maybe it's worth noting for the future as to whether or not some of these may be modified more permanently. So I think it would just be helpful to get some, and I realize that the administration is completely overwhelmed right now, but if there are one or two people who could just come in and speak to us about the impacts, that would be helpful.
So if you look at
your, oh, go ahead.
I'm sorry. If you look at your agenda for tomorrow,
that's what I was going to say.
You'll see it is the topic of the day with a number of folks. And actually, this was a request from a number of people to have a continuation. And some of the provisions, have involved like the rules committee, and some of us, the chairs of committees, have sat down to work with the administration to build the emergency rules or to hear about what the requests were during COVID. So there's a lot of work that's gone on with this behind the scenes. And the people who will be coming in tomorrow will be those who have been most affected. And then I think your question is a very good question. Are these provisions useful or not? And as Jen said earlier, there are some things that are just not being suggested to go forward, like the provider tax that wasn't seen as something we should continue. So
that flexibility is already built in. It's not in here because it was originally written as during the state of emergency and for 6 months after. Right. So it didn't need revisiting to extend. It already travels with the duration of the state of emergency.
Yeah. Okay, good. So we'll get the testimony and we'll see how it goes, what your thoughts are. And frankly, there may be some things that you believe as committee members that are important to have here that are not here. And I haven't heard of any yet. I've heard of some suggestions for improving the system as a whole that would be statutory. So I'm not going to bring those up right now, but going forward, we can think about that. And then, as Senator Hardy said, I think a really good suggestion, some of we don't need to ask the question necessarily with the bill itself, but as we look at our draft emergency committee bill for mitigating healthcare problems in the future, emergencies, that some of these things become part of the playbook, so I agree with that. Any other questions from committee members at this point?
Just a kind of picky question about the pharmacists who can refill a prescription. Is that a one-time refill? It doesn't, state that. Could it go on? I mean, if they can't get in touch with the doctor the second time that the refill is expiring. That, and the second question I had was regarding providers who are doing just telemedicine. I think, Jen, you said they didn't have to register unless physically present. Why wouldn't everybody have to register so that we know?
That's the way the language was. That's the way the committee put the language in. I think a lot of this was at the time when we weren't sure what was going to happen, and there was concern about putting barriers up for treatment if somebody could find a provider who was able to see them over telemedicine.
Well, and the thing is, it's really related to the out-of-state folks, I think, is pretty critical.
Yes, that's what it is.
And so there are people, for example, who live in Bennington who rely on New York State physicians. And then there are people who might rely on New Hampshire physicians. So, and then in my neck of the woods, there are patients who rely on New York State. Mm-hmm. So having that provision in place would continue to allow access to the healthcare provider through telemedicine when they can't get in the car and drive.
Yeah, and
that's just one of the issues, I think.
Right, but as far as knowing who's doing this, and there's something we need to do, at least have a list of them, whether it's, I don't know how.
Good question. We'll that's a very good question. We'll run that out and see what we get back.
Jen, what section are we talking about right now?
That was in so looking at section 17. I mean, it's section 1 in the bill, but section 17. So it's on bottom of page 9 is where it starts.
Okay, thanks.
And to Senator Hooker's first question about the prescription refill, the language is extend an existing prescription. It doesn't specify how long or how many times, and I don't know. It's a good question. I don't know if the Board of Pharmacy has provided any guidance. We could look on their webpage, and I know Lauren Hibbert, from the director of OPR, is coming in tomorrow and may be able to give you some information about how that's being implemented or whether there should be some clarifying language added.
Thank you.
Yeah, I think that's a really good point. If the prescription was for 2 refills, to have the pharmacist decide to extend it to the 3rd time would be, that's the question I think you're asking. Yeah. Make sure.
Right. Or could they extend it for, a 3-month period or something? Right. I mean, so I think it is a fair question.
I thought it was a 30-day period, but maybe we'll have to circle back and.
Right. That was the maintenance medication they could allow, or insurance has to allow early refills. So you can have a 30-day supply, but this other one does not specify. And I will look at the Board of Pharmacy rules and see, or website, sometimes they have some helpful guidance documents.
And with regard to the maintenance drugs and stuff, I think the genesis of that was kind of the supply chain hold up, and I just wonder how that's going as well, and that may be something that somebody can fill us in on.
Right. I think particularly the lack of availability, the therapeutic substitution due to lack of availability was concerns about supply chain. And I think some of the maintenance medication was more trying not to give people a reason they had to leave their house and go, interact in public.
So you're going to hear from a number of people who I hope are listening in now and are jotting down some of the questions, and we'll get some answers. And if we don't, we'll make sure that we do get answers. Any other questions? No? Okay. Okay. Jen, this has been really perfect. Very helpful, I think. Now that we've gone through the bill, and I will say this because some of you haven't really been through this before, and so it's important now. You've got your feet on the ground with it. And as we work with House Healthcare tomorrow, many of them have already worked through this in the last session, and then they've been, I sent the bill over, the draft over to Representative Lippert, and he knows it's on our webpage, so they'll have it to look at. So hopefully tomorrow, when we're listening to the testimony, we'll all be on the same page, and we'll try to structure it so that all the questions that you have and that you've written down can be answered. So we'll sort that out. And if we can't get the answers tomorrow, we'll get them another time. We need that. You need that for reassurance. I know. So Nellie, I'm thinking that if it's possible to ask Amarin if she's available in 12 minutes. So at 10 after 11, rather than 11:30, we can begin to go through. Can you check her, Nellie? Can you check and see if she's available?
Yep, I'll email her and see if she's there.
Okay, that's good. And let's just hold a minute right here till we hear back. If she is not available, then I have a couple things I wanted to talk about at the end of the meeting, so I'll put them in the middle. So we'll just sit here and wait for a few minutes.
Senator Lyons.
Yes, Senator Terenzini.
Nice to see you.
Good to see you.
Can I ask Senator Hooker a question while we wait?
Sure. Depends on what it is, but go ahead. Go ahead.
We are still live on YouTube, just as a reminder to everybody.
We're in committee discussion mode, so go ahead. And then I do have one thing to add. Go ahead.
I just wanted to see if Senator Hooker saw that she was the star of Channel 5 News last night.
Oh.
I saw that you were on today.
Oh, was it on today, you and I again?
Yeah.
Can I ask the topic?
We're trying to get homeless shelter employees put on the priority list for vaccinations.
Ah. Okay. Troublemakers for sure. No, that's good. I'll have to look it up. I'll look at it. I'll see what you said. I do have a comment to make while we're waiting to see if Amarin's available on the bill that we just went through. We did have a request over the weekend from folks who worked on, we had another, I forget what bill it is in, Jen. It may be 159 or another separate bill. I think it's a separate bill on advanced directives. And
Yes, it was a separate bill.
right,
was
so we
Page
had
750.
we had allowed people to develop and sign off on their advanced directives for healthcare on video, on audio, video. And so the folks who have done that are looking for a similar extension to the one that we have in the bill. So it would be 3 months after the emergency, or I forget what the exact date they're asking. But they're coming in on Thursday, so we'll have a chance to hear their request. That would be Cindy Bruzzese of the Ethics Network and I forgot who else, but it's on your.
Olivia Graffio Cohen from Legal Aid.
Yes, okay, that's right, Legal Aid. Yeah, because they were the ones that made the request in the first place.
That's one that'll be interesting to see how frequently it was used.
Yes,
during-
it will. Yes, it will. I think particularly during COVID,
Yeah.
people
I think a lot of
people were very proactive in looking at their future healthcare and financial needs. Still are. So that'll be coming up on Thursday. And if we have any loose ends to tie up, there may be some room on that day to invite folks in to answer final questions on the bill, on the committee bill, flexibility bill. Nellie, any word from Amarin?
Nothing yet.
Yeah, she might be tied up in another committee.
Yeah, I'll keep you posted if I hear anything
All right,
for
so-
her time.
Okay, here's my suggestion. Let me go through some of the things that I was going to share with you, and then we'll take a break and we'll come back when Amarin is available. She's on the schedule for 11:30, so we'll try and have a little break before 11:30. So just in putting this week's agenda together, it's been a real heavy lift. People are unavailable because they're working in other committees or they have other commitments in the administration. I'm talking about the administration for the Budget Adjustment Act and others. This is an ongoing stressor that we all feel when we're setting up our agendas. So you'll notice that you'll see people coming in from the administration one day and then another day, and it doesn't look like it's cohesive or have, continuity. That's just the way it is. And that's the way it is in this committee. There's so, we also have testimony on some of the bills we're interested in and the people we have in, including our wonderful Ledge Council or Joint Fiscal Office. Those folks are also stretched to the limit in going to other committees. So we do what we can do to keep an eye on the prize, and we're that's pretty that's a good quote for Black History Month. Anyway, so we're going to keep our eyes on the bills we're working on, and I thought it would be helpful to let you know, and as you can see from the agenda, our focus will be on this committee bill, the pandemic bill, to get that completed as much as possible. The emergency services wellness bill, S42, we want to try to finalize our work on that as quickly and as soon as we can and complete our testimony. And then we have today, Amarin is going to be going through S48, which is the nurse compact bill. And that's also a pretty important bill in terms of workforce and ensuring that we have sufficient folks. It's been I'm glad we're in Vermont, let's put it that way, but nevertheless, we have a nursing shortage, among others, a primary care issue, and we'll be working on that one too. But so those are the bills we're going to work on this week as much as possible. And then we'll carry over till next week, at least S48, possibly the other two. And then we'll be starting work on some other bills and also looking at whatever is coming to us in terms of budget. So, when I say budget, I mean the federal funding that we may be getting and guidance there. So we'll try and get an update on that. And so just to give you a sense of, I don't like the discontinuity any more than you do, but on our agenda, but we work to fill the holes and to make sure that we have the information we need going forward. And then as we get bills, I think it's important for us to just look through those bills and know what they are so that we can set priorities. I obviously have some ideas for what we'll be doing, and I hope that you will enjoy working on those as well. And then we'll go from there as a committee. So questions, answers. Amarin's going to be here in 2 minutes. Let's go silent for 2 minutes. And then maybe we'll be able to finish a little bit early. Would you like let's take a 5-minute break right now, please. Let's do that. We got 5 minutes. Hello, Amarin.
Hello, how are you?
I'm well. How are you?
I'm good.
It's very good to see you.
Yes, you too, in this unusual video world.
It is. It's nice to have you working with us. I know Betsy Ann Rask worked with us on this bill last session, and but she's moved on to, is it higher places? Different. Oh, we'll see. I don't know if the rest, I'm going to wait just a minute here while the rest of the committee gets settled in, and then I'll have you introduce yourself. I think first we'll introduce the committee, because I don't think you have been, I don't think you've met with us before. So that's, yeah. Okay.
I had a process question for you.
Certainly.
Does your committee do screen sharing, or will you be following along on a secondary device?
We're happy doing screen sharing.
Okay.
Yeah. And so Senator Cummings, are you there yet? She will be there. There she is. Oh, terrific. Okay, so why don't we just go around, and we'll start with Senator Hardy, and then I'll have folks introduce themselves.
Hi, Amarin. I'm Ruth Hardy. I'm a senator from Addison County.
Nice to meet you.
Senator Hooker.
Good morning, Amarin. I'm Cheryl Hooker, Senator from Rutland County. Nice to meet you.
Nice to meet you.
And our other Rutland Senator.
Good morning. 5-minute pizza break. Nice to meet you. I'm Josh Caranzini, Senator from Rutland County.
Nice to meet you. Good morning.
You're muted, Senator.
No,
Oh,
not.
No, you're not. No, you're not. Take it back.
Just didn't call on me like everyone else. I'm Ann Cummings. I'm the one old face. We've met before.
We have.
I represent Washington County.
Good morning.
All right, that's terrific. And just, I do represent Chittenden County, but we have met several times for lots of different things. So Amarin, we have S48, and given the time that we have, we could probably spend a lot of time doing this bill. So give us kind of the overview of the bill. And I know there are sections of the bill that are more pertinent to GovOps, and they have gone through the bill in the past, and we would like them to weigh in on the GovOps sections. And you could help us understand where our jurisdiction begins and ends. So that would be helpful. Can you do
So
all?
I have two documents. One, I have the language of the bill itself with some highlighted sections that I could walk through with you. I've also provided Nellie with a handout for the committee that just gives very, very high level. And I'm happy to do either. I wasn't sure as to timing for this morning. So it's a long bill. It's about 35 pages. So
yeah, let's start with a summary. Thank you for doing that for us. I think this will help us, and then the next time we'll go through it in a little more detail, and we'll put the bill up for the amount of time you think it'll take.
Okay.
And yeah, good.
Senator Lyons, I don't have the summary on my.
Refresh your webpage. Go to the little circle thing and do that.
I can also screen share if that would be easier.
Yeah.
That would be fine. I just
okay.
For it and didn't
do that. That'd be good. Everybody else okay? Got it? Got stuff? Good.
Okay. And can you see my screen?
We can, and we're pretty relaxed with this process. So if you don't mind people jumping in with questions.
That sounds great.
All right, terrific.
Okay, so I just wanted to, as a start, point out that this is a bill that some of you saw last session.
You better introduce yourself.
Oh, I'm sorry. Thank you, Senator.
There you go. For
the record, Amarin Aberdaly, Legislative Counsel. this is a bill that some of you saw last session in the form of S-125. This is an act relating to Vermont's adoption of the Interstate Nurse Licensure Compact. And S-48 would enter Vermont into the Multi-State Nurse Licensure Compact as amended by the National Council of State Boards of Nursing. I looked at their website this morning and they have 33 states listed as member party states in the compact. And by entering into such a compact, Vermont is agreeing to the multi-state terms of licensure for registered nurses and licensed practical nurses and vocational nurses. By enacting this bill into law, Vermont would be entering basically into a contract with the other parties that are part of the compact. And the important point to note about that is that this means that Vermont is not able to amend or change any of the sections of the compact. The state would need to adopt the language basically as is, because the language needs to be the same for all party states that are in the compact.
Can I just quickly ask you a question?
Yes.
And as I recall, APRNs are not included, and so we don't have advanced practice nurses would be not included in the compact.
That is correct.
Okay.
So the compact has some main provisions, right? The idea is that a compact license issued in a home state, which means where a licensed nurse has their primary state of residence, and the primary state of residence has to be a compact state. So once the nurse is issued a compact license, then the nurse is able to practice in each compact state. So there are some important terms that will come up a lot in discussion of this bill. A party state, which means any state that has adopted this compact and has agreed to the terms of the compact. A home state refers to the licensee's place of residence and where they get their multi-state license. And then a remote state means a state that is a party state. So it's a state that's part of the compact, but it is not the licensee's home state. So if you have a Vermont licensed nurse who is practicing also in New Hampshire as a party state would be a remote state for that licensee, and Vermont would be the home state. So those are some important definitions to think about as conversation around this bill happens. So once a nurse moves to a new home state, the nurse must apply for a new license in that home state, and the prior home state compact license is deactivated. And there are reasons for this. A home state licensing board has different authorities in terms of how they what actions they can take against a licensee versus a remote state. So a remote state may be able to take actions in terms of that licensee's practice within the remote state, but a home licensing board can take action as to the multi-state license itself, and affecting that licensee's ability to practice in other party states. So if and it's important to note also that if the new home state is not a compact state, the prior home state license converts to a single state standard license. So moving down to the bottom of page 1, the compact outlines the requirements for obtaining licensure within a compact state. There needs to be a criminal background check. You have to meet all of the home state's qualifications for initial licensure and license renewal. You need to have graduated from an education program approved by the home state's licensing board or from an approved foreign pre-licensure education program. You must have passed an English proficiency examination if the applicant graduated from a foreign pre-license education program that was not taught in English, or if English is not the applicant's native language. The applicant must have passed the NCLEX examination or recognized predecessor, and the NCLEX is the National Council Licensure exam, and there is one for registered nurses, and then another one for the LPNs.
I have a question that is totally unrelated to this, but very much related to it. And that is, as you're looking at the foreign pre-license and the English proficiency information, I guess my question is, I wonder if there's any institution in the state that has a focus on educating foreign applicants of this type. So it would have to be not only English language proficiency, but some special language support for, medical language. I don't know. Obviously, Middlebury has a language school, but it's not about training people to get into a vocation like this.
Mhm.
Anyway, we'll just leave that for now, but just a question.
Okay. The applicant must be eligible for or already holding an active unencumbered license. The applicant must not have been convicted or found guilty of a felony or of a misdemeanor related to the practice of nursing. The applicant cannot be currently enrolled in an alternative program, which is usually for nurses experiencing substance use disorder issues. The applicant is subject to self-disclosed participation in an alternative program, and the applicant needs to have a valid U.S. Social Security number. So a nurse is required to comply with a compact state's laws governing the practice of nursing when providing care to a client in the compact state. And that means that a nurse, for example, whose home state is Vermont, but is able to practice in New Hampshire through this compact, would need to comply with all of New Hampshire state laws governing the practice of nursing when providing care to a client in New Hampshire.
Madam Chair, may I interrupt? Ameren, the provision about the Social Security number, how does that relate to if someone has a green card to work here? Do they have a Social Security number? How does that apply to green card holders?
That's a good question. I don't know, but
Okay.
I can look into that.
Yeah, I think
great.
we did have that conversation last time, and so it's part of the compact, and I think the decision was made up front to include only those with Social Security numbers, but you're right, it's a interesting question. Well, maybe we could sort that out a little bit with states that are currently involved with the compact or how it was determined.
Yeah, it would just be nice to know
Yeah.
whether or not they're included, and if they're not, why not? And Ameren, just a follow-up question. It's not this bill. We cannot amend the bill because it is basically the compact we're approving with this legislation. So it's a sort of all or nothing kind of thing. Is that correct?
That is correct.
Okay.
The only change. Oh.
Sorry, go ahead, Ameren.
The only changes we have made is to conform the compact to the style of our laws, but otherwise it is the exact language of each other party state's compact.
Can you remind us what's called sort of the critical mass of states, and the states who are first in, so they have the first seat at the table for rules and changing recommendations for the compact?
So the compact came into effect, I believe it was the earlier of December 2018, or 26 states joining. Each compact state does have, and we'll be getting to this in a little bit, but each compact state does have one representative that is entitled to have a vote and would be able to participate in all of the rulemaking that occurs by the commission.
Okay, I mean, that's good enough. I don't want to interrupt the flow of the bill, so go right ahead.
Okay. So each compact state may discipline a nurse's license in that state. And this includes the ability to discipline based on factual findings of another compact state. If a home state disciplines the nurse's license, the nurse's ability to practice under the compact license is suspended until all encumbrances have been removed from the home state license. And this is what I alluded to earlier, where the home state really has the most power over the multi-state license itself, whereas remote states are able to discipline based on conduct within their own state and the ability to practice within their own state. Compact states are required to share licensure info, including any disciplinary actions in the compact's coordinated licensure information system. And you'll see there's a pretty significant section on this in the bill that really lays out what exact information has to be included, the form and timing of when that information is included, restrictions on how confidential information is included, and whether it can be disclosed. So that's a pretty hefty section, but this is a system that allows party states to see what types of disciplinary actions or encumbrances there are on someone's license, or if someone's been denied licensure and things like that. And each compact state is required to submit a certain set of information into that system. As I mentioned, each compact state has one representative, which is the head of the state licensing board or their designee, on the compact's Interstate Commission on Nurse Licensure Compact Administrators, which has rulemaking authority to administer the compact. There's also a significant section about the commission's powers, practices, process for rulemaking. The bill also lays out how often the commission meets, which I believe is at least once a year, and it lays out notification requirements in terms of rulemaking, as well as when meetings must take place in the public versus when the commission can have a closed meeting. So that is a significant section that you will see within the bill. And then one of the last notes here is just about how does a state remove themselves from the compact. And the way to do that, it would be to repeal the enabling law. And it's important to note that even if a state decides that they wish to withdraw from the compact, there is a 6-month sort of wait period before that withdrawal will take effect. And during that 6 months, the state would still be required to meet all of the requirements of the compact while they're waiting out that 6-month sort of wind down period. And so those are the highlights. There's a lot more detail I could get into, but
that's a short bill. I agree. Why don't we do this? Committee questions regarding the summary that we've just gone through, and then we'll start digging through the bill a little bit for a little while. So questions. So generally, just to recap, the bill allows for certain types of nurses to be licensed in a home state, and then because they have a compact license, they can practice in other compact states, and they are regulated sort of the day-to-day work in the remote state. But if there's something egregious, the home state can, if there's cause, could remove the license or have professional for the remote compact license. Sorry. So, and then there are rules, or there's some sections on how the compact council works, what their authority is, and some of that actually dips into GovOps stuff, but we need to be aware of what's there. Senator Hooker has a question.
Thank you, Senator Lyons. I'm just curious to know how many of the northeastern states are part of the compact.
Let me stop sharing for a moment. I pulled this up this morning. I'm not sure I still have it up. I do not. Just one moment.
Well, you know what? This is a question that needs to be answered, and when we have testimony on the bill, We'll get it from the Board of Nursing, OPR, and others. That's a very good question to ask Senator Cummings.
My memory says that New York was the one
Right.
was the big state that locally that hadn't joined. I'm not sure about the others. But we did this bill last year.
Right.
Right?
Yes.
Is there a
The
did
bill,
it just not get through because of timing, or did it not get through because there were issues?
so the bill did get through the Senate, and then it landed in House Healthcare, and there wasn't there wasn't consensus on the bill. The reason there wasn't consensus on the bill is because an issue was brought up about whether or not the compact would allow for more traveling nurses. And traveling nurses were seen as problematic by nurses who are working in the state and live in the state. So that's an issue, and we may hear about that as we're taking testimony again. When we heard testimony from, I believe it was a nurses union at in my area in UVMMC, who indicated that initially it was one person who testified and said that she did not speak for the union, but she felt that there would be an effect as a result, on traveling nurses. And it's interesting because when I worked with the girls' state the summer before on the bill, I had brought up the issue of traveling nurses, and I probably shouldn't have. No, so that's the issue, and it stopped in House Healthcare. I don't know if that was the thing that did it, but there was a change in testimony. In our committee, it was one person, and then by the time it got to House Healthcare, it was a union group. And so I don't know any other than that, Senator, and I don't know why else it would have been waylaid. I do know that this is a top priority of the Rural Healthcare Task Force when they completed their work, and we'll get them to testify. Having the nurse compact in place was an important aspect of improving the workforce in the state. So there's some ground to cover here, and they're good questions to ask. Senator Hardy, and then back to Senator Hooker.
I was just looking up, Ameren may have already gotten to this information too, but it looks like from the website, Maine and New Hampshire are members. Rhode Island has pending legislation, but the rest of New England and New York and Pennsylvania are not yet members. It seems like we are a little bit of a gray area. The other, Minnesota and Illinois are not members. California and Nevada are also not members, but
I don't know. We'll have to take testimony on that again. So thank you. Thanks for looking that up. Good. Senator Hooker.
Just a clarification on the requirements for traveling nurses as opposed to compact nurses as far as licensing goes, and how does that really intersect with this?
I think I know the answer to that question, but I think that's an excellent question to ask when we have testimony from OPR and the nursing group. Okay, so write that down. We got, don't forget your questions. All right. Any other questions? Why don't we take a walk through the bill, at least up until we get to the parts that really might relate more to GovOps. We can skim through those, but GovOps is the group that will be taking some lead on committee process and executive sessions and all of that. So.
Sure. I'm going to pull up my version, which has some highlighting. It's a little easier
good.
to
We got
follow.
magic. And Amber, why don't we plan on going for another 12 or 15 minutes, and then we'll remember where we are and come back to it.
Okay, that sounds like a plan. Can everyone see my screen?
Yes.
Nods. Okay, perfect. So as I mentioned before, the form, format, and text of the compact have been conformed to the conventions of our Vermont statutes, but otherwise there have been no language changes from the compact adopted by other states. I'm going to skim past the findings and declaration of purpose unless there are objections. Oh.
Let me ask this question. Is the yellow, are those the changes that we made during the last session?
Nope,
Or not?
No changes in
okay.
here. These are just, it was easy for me as I was going through to kind of pick out some of the pertinent parts for me. And I thought this might be an easier way for you to take a look. So at the beginning here, we have the findings, right? And the party states find that the expanded mobility of nurses and the use of advanced communication technologies as part of the nation's healthcare delivery system require greater coordination and cooperation among states in the areas of nurse licensure and regulation. And the party states find that the current system of duplicative licensure for nurses practicing in multiple states is cumbersome and redundant for both nurses and states, and that the uniformity of nurse licensure requirements throughout the states promotes public safety and public health benefits. So the general purposes of the compact are to facilitate the state's responsibility to protect the public's health and safety, ensure and encourage the cooperation of party states in the areas of nurse licensure, facilitate the exchange of information between party states in the areas of nurse regulation, investigation, and adverse actions, promote compliance with the states governing the practice of nursing in each jurisdiction, invest all party states with the authority to hold a nurse accountable for meeting all state practice laws in the state in which the patient is located at the time of care, decrease redundancies in the consideration and issuance of nurse licenses, and provide opportunities for interstate practice by nurses who meet uniform licensure requirements. This compact also lays out all of the definitions that will be used in here. Some important ones to know about are adverse action, which could mean any administrative, civil, equitable, or criminal action permitted by a state's laws that is imposed by a licensing board or other authority against a nurse. And moving down, unless anyone has any specific questions about definitions, I wasn't going to go into too much detail here. As I mentioned earlier, important definitions to know: what is a home state? The party state that is the nurse's primary state of residence. And party state means any state that has adopted this compact, and remote state means a party state other than the nurse's home state.
I think re-emphasizing the definition of nurse is important, so there's no confusion that advanced practice nurses are included in this. So it's RNs, LPNs, and VNs.
Yes, that is correct.
Cameron, could you remind us what a VN is again?
It's a vocational nurse.
Okay, thank you.
So general provisions. A multi-state license to practice registered or licensed practical or vocational nursing issued by a home state to a resident in that state will be recognized by each party state as authorizing the nurse to practice as an RN or LPN or VN under a multi-state licensure privilege in each of the party states. So each state must implement procedures for considering the criminal history records of applicants for initial multi-state license or licensure by endorsement. Each party state must require the following for an applicant to obtain or retain a multi-state license in the home state. And this is the list that I went through in the previous handout. So the nurse must meet the home state's qualification for licensure renewal of a license. as well as all other applicable state laws, has graduated or is eligible to graduate from a licensing board approved RN or LPN VN pre-licensure education program, or has graduated from a foreign RN or LPN VN pre-licensure education program. The applicant has, if a graduate of a foreign pre-licensure education program not taught in English, or if English is not the individual's native language, successfully passed an English proficiency examination. The applicant must have successfully passed an NCLEX-RN or NCLEX-PN examination.
So
Yes.
I'm going back again to the English proficiency examination, and it doesn't specify which. So I'd like to know what an English proficiency examination includes. So at what level, and does it include the medical terms and information that one would need? And then I go back to my entrepreneurial question about maybe we need to put something in place in this state. But anyway, we'll get OPR to answer that question, I think, maybe. I don't know. We'll see.
Okay.
It's a question. Okay.
It's a question. All right. The applicant must be eligible for or already be holding an active unencumbered license and have submitted in connection with an application for initial licensure or licensure by endorsement, fingerprints or other biometric data for the purpose of obtaining criminal history record information from the Federal Bureau of Investigation and the agency responsible for retaining that state's criminal records. The applicant must not have been convicted or found guilty or entered into an agreed disposition of a felony offense under applicable state or federal criminal law. The applicant cannot have been convicted or found guilty or have entered into an agreed disposition of a misdemeanor offense related to the practice of nursing as determined on a case-by-case basis. The applicant is not currently enrolled in an alternative program, nor is the applicant subject to, the applicant is subject to self-disclosure requirements regarding current participation in an alternative program, and the applicant must have a valid U.S. Social Security number. So all party states shall be authorized in accordance with existing due process law to take adverse action against a nurse's multi-state licensure privilege, such as revocation, suspension, probation, or any other action that affects a nurse's authorization to practice under a multi-state licensure privilege, including cease and desist actions. So if a party state does take such action, it needs to promptly notify the administrator of the coordinated licensure information system that we were discussing earlier. So there's a reporting requirement here. And then the administrator of the system must promptly notify the home state of any such actions by remote states. And then the home state would make a determination whether further action is warranted. A nurse practicing in a party state must comply with the state practice laws of the state in which the client is located at the time service is provided. And it is important to note that the practice of nursing is not limited to patient care, but shall include all nursing practice as defined by the state practice laws of the party state in which the client is located. Individuals not residing in a party state shall continue to be able to apply for a party state's single state license as provided under the laws of each party state. So in this case, if you have an individual who's living not in a compact state, but wishes to obtain a license from a compact state, they would be granted a single state license and not a compact multi-state license. And then there are more provisions here about any nurse holding a home state multi-state license on the effective date of this compact may retain and renew the multi-state license issued by the nurse's then current home state, provided that a nurse who changes primary state of residence after this compact's effective date must meet all applicable requirements of subsection C of this section to obtain a multi-state license from a new home state. Okay, so we're looking at people who move from one multi-state license state into a new home state where they can obtain a multi-state license. And a nurse who fails to satisfy the multi-state licensure requirements in subsection C of this section due to a disqualifying event occurring after this compact's effective date shall be ineligible to retain or renew a multi-state license, and the nurse's multi-state license shall be revoked or deactivated. And then here's one of those instances where the rules adopted by the commission would take effect, right? So those rules would apply to how the nurse's multi-state license would be revoked or deactivated.
I have a question, and it goes back to my earlier comment regarding travelers. So there's nothing in here that says in order to be a traveling nurse, you must have a remote license, allowing for the state. So I'm just wondering if there's an advantage, and this is this is rhetorical. Okay, so everybody just think about it. I don't know if it's a question or not. Is there an advantage to having traveling nurses be compact nurses? And I'll just leave it at that, but process that a little bit. I don't know.
That was the question I had, Senator. And what is the advantage of the compact as versus the traveling nurse? And are there restrictions on the compact nurses that are not on the traveling nurses? You mentioned that traveling nurses were, quote, a problem. And does that have to do with...
Yeah, no, they're only a problem in that they're very expensive.
Exactly. And
yeah.
If there was some kind of restriction on the compact nurse and what they're allowed, what their pay is.
So what's the link there, if any? We'll explore that as we hear from folks. And I don't know, Amran, whether you can help us with that one or not, but it's an interesting thought. If it's not currently part of the compact, then it's something we have to look at ourselves. Senator Hardy.
Yeah, sort of a related question. Thank you, Madam Chair. Is can a nurse still hold just a Vermont license and not apply for a compact license if we were to pass this legislation? So if they didn't want to ever practice in another state and just wanted to stay practicing in Vermont,
write your question down. Write your question down.
Amran might know this. I mean, I don't know.
I can answer it too, but I think it's important to hear the testimony. But Amran, you answer it. Go ahead.
I do not know the answer to that.
Okay. All right. Okay. We'll save that, but the answer is yes. Okay. And I think there was some conversation about that. That's why I think it's a simple answer of yes. Probably it's more important to have some information behind it. So we'll get it. Good question.
And Senator Lyons, I'll write down another question, but it has to do with if a nurse joins the compact, then he or she can go to any of the compact states without applying for license?
Ask Amran that question.
Okay.
Yes, you would be considered licensed in any party state. You would, of course, need to, that's not to say that you could just move to a different compact state, right? You still need to maintain the distinction between what is your home state and what is you working in a remote state. But yes, the idea is that if you are licensed with a multi-state license, that you would be authorized to practice in any of the other compact party states.
Thank you.
It doesn't change where you pay your taxes either. All right, go ahead.
Okay, I just wanted to check in about time. I think we've been about 14 minutes. Would you like?
Right.
We're about to start a new section, so.
Well, let's not.
Check
let's
in.
not. Oh, which section are we? We have finished with
now. So now we are on to the application process.
How much time would you need to go through the application process? Oh, it's only, we have 9 minutes. Let's end here. This is a good place to end, I think.
Yeah.
Committee, are you okay with that, or would you like to continue? Vote. Are you okay with stopping? Raise your hand if you say yes.
Sure.
Yes.
I'm assuming
Okay.
we'll get back to this, right? I mean,
No, this is it. This is it.
Yeah.
No, of course we are. Yeah. No, we'll be back to it, and we'll put some testimony up that will help answer the questions that are coming up and that we have. Amarin, thank
Yes,
you.
you're welcome.
Yeah, it's great to have you here. And as you can see, there's a lot of interest in the bill and a lot of questions. So we'll get some testimony. We'll finish up going through the bill first, have you go through it with us, and then we'll follow that with some testimony. And we'll try to do those two things together. So thank you.
All right.
You can take your screen down.
Oh,
if you'd like. Terrific. Thank you. So committee, on a unanimous vote, we will informal vote. We'll call it a day, and we'll be back tomorrow morning at 9 o'clock. And FYI, again, we are meeting jointly with House Healthcare. I forget what time that starts, but check your agenda. And we'll be talking about the flexibility bill again. I just want to.
It starts at 9.
It starts at 9. Thank you, Nellie. And we'll have testimony from folks on the flexibility bill. So just take a quick review, maybe through the summary again, remind yourselves of what questions you might have, and we'll bring those up with folks and try and get them answered. Okay? Okay.
sounds good.
Sounds great. Thank you all for today, and see you tomorrow. Take care.